A wonderful good afternoon. It is my pleasure to welcome you to the IARS virtual education webinar today. It is entitled Heparin and Hamburgers, Perioperative Implications of Alpha-Gal Syndrome for the Anesthesiologists. My name is Matthias Riess, and I will be moderating this one-hour session this afternoon. I'm an anesthesiologist and physiologist at Vanderbilt University and at the adjacent VA Medical Center in Nashville, Tennessee. I do split my time between the operating room and a basic science research lab that focuses on improving outcome after cardiac arrest and resuscitation. I do not have any conflict of interests. Next slide, please. There are no conflicts of interest from the IRS, as this was not supported by any commercial entity. We have three excellent speakers lined up today who will talk about a topic of growing prevalence that is beyond the epicenter in the southeast of the United States. And I will introduce each speaker in more detail before their respective presentations. Next slide, please. If you missed the 2025 annual IARS meeting, there are on-demand recordings available now for purchase. Registered attendees have complimentary access, and for more information, you're welcome to check this link or the IARS website. Next slide, please. Speaking of the annual meeting, please mark your calendar for the next annual meeting in Montreal, in Quebec, Canada, which takes place from May 1st to May 3rd in 2026. The call for sessions will open later this month. Please visit the IRS website to submit your proposal. Next slide, please. If you have questions after the webinar has ended, you're welcome to place them into the doc matter, and we can answer them offline. Next slide, please. Upcoming webinars in July and August include the topic Harnessing Artificial Intelligence to Mitigate Opioid Risk, which takes place on Tuesday, July 8th at 4 p.m. Eastern Time. And another one called Update on Donation After Circulatory Death Heart Transplantation, also on a Tuesday, that is August 12th, also at 4 p.m. Eastern Time. Next slide, please. Again, we go through the three presentations, and then we have time for question and answers. This is a live session, so feel free to type them into the Q&A button of your Zoom app. Thank you so much. So without further ado, we are going to get started with the first speaker. This will be Dr. Kahwash. He is a board-certified allergist and immunologist at Ohio ENT and Allergy Physicians in Columbus, Ohio. Before, he was an assistant professor of medicine at Vanderbilt University Medical Center in Nashville. During his tenure there, Dr. Kahwash was actively involved in clinical research and published in leading journals on topics such as exercise-induced asthma, allergic skin disease, and alpha-gal. He's an active member of the American Academy of Allergy, Asthma, and Immunology, where he had several leadership positions and currently serves on the council of the foundation. Feel free to connect with him after the session, also through LinkedIn. He regularly shares insights on healthcare-related topics. His topic today will be alpha-gal syndrome. What is it, and why is this important for patient care?
Thank you, Dr. Riess. Before I get started, I am going to switch over to my personal laptop, which I have right here next to my work laptop, because of some technical difficulties related to the work laptop. So I apologize to the attendees and to my fellow panelists. It should take no more than 20 seconds. Thank you so much for your patience. Okay. Okay, Sorry for that delay and sorry for the echo there as I was switching over to what I now have. And I hope everybody can see this on the screen. And thank you again to the introduction by Dr. Riess. My name is Basil Kahwash, and the subject of my presentation is alpha-gal syndrome. What is it, and why is it important for patient care, both to me as an allergist immunologist and to all of you as anesthesiologists? Here's some information about me on this slide. Like Dr. Riess said, I'm a practicing allergist immunologist now at Ohio ENT and Allergy Physicians Group in Columbus, Ohio, and you can see my disclosures here on this presentation, none of which are pertinent to anything that I'm going to be speaking about today, and I will not be discussing any off-label or investigational uses. So to start us off with this big question, what is alpha-gal syndrome? Alpha-gal syndrome is the subject of our presentation today, so we need to start off by defining what it is from the specialists who are most commonly those that are going to be called upon to treat it, who are allergists and immunologists. Alpha-gal syndrome is also known as an acquired red meat allergy because it's associated with red meat as the most common provoking trigger for an alpha-gal reaction, although as we will see later on, both from me and from the other panelists, there are other things that can trigger allergic reactions in patients with alpha-gal and is acquired. Therefore, patients do not, it's not one of those food allergies that tends to develop in childhood. It can be acquired later on in adulthood. Essentially what it is it's an IgE-mediated reaction, not to any protein, but to this galactose alpha-1,3 galactose carbohydrate, which is bound to mammalian protein surfaces. And to date, really, this is the only carbohydrate IgE-mediated allergy that is described in the allergy and immunology literature. So there are reasons why that's clinically significant that I'm going to get into. Most cases, at least in the United States, we believe are due to sensitization by the Lone Star tick bite. Essentially, a Lone Star tick will bite some sort of a mammal and then proceed to bite a person, and then the person who is bit by the Lone Star tick will develop sensitization to the components of the Lone Star tick saliva, and among them are this alpha-gal protein. It's a really interesting pathogenesis that is pretty well sketched out in the literature now. You can see what alpha-gal is in this picture on the right side. So that's what when I describe a carbohydrate bound to a protein, essentially this is a carbohydrate moiety that is covalently bound to an amino acid on mammalian proteins. So that's where the allergic reaction, the IgE, is directed against in these patients that have alpha-gal allergy. What happens in these patients is that they develop delayed symptoms following red meat ingestion typically. So the patient will eat a red meat containing meal, and then they'll have what looks like an anaphylactic reaction 3 to 6 hours after the meal. Anaphylaxis, of course, involves multiple organ systems, so it can be vomiting, wheezing, hives, angioedema. Sometimes in extreme situations, you can see drops in blood pressure and some neurologic changes as well. But this will tend to occur 3 to 6 hours after ingestion of the allergenic food. That distinguishes it quite a lot from other food allergies. Most other IgE-mediated food allergies, think about peanut allergies, those symptoms develop 5 to 30 minutes after ingestion of the allergenic food. Immediate anaphylaxis to beef and pork, so among the top 9 food allergens, beef and pork are not listed there. So patients who have IgE-mediated allergy to beef and pork that is not alpha-gal, that's very rare. So in my world, if a patient says, I think I'm allergic to meat, that to me suggests alpha-gal, because we know that the immediate onset food allergens are going to be things like peanut, tree nuts, egg, milk, soy, etc., which are all allergies that occur to the protein, not to any carbohydrate within those foods. And just to refresh everybody's memory, since I'm an allergist and immunologist, this is a graphic that I think about every single day, but all of you all may have seen it in medical school and it may not be front of your mind as it is with mine. But essentially, when we talk about IgE-mediated reactions, we're really talking about this type 1 hypersensitivity reaction, as we call it, which typically is caused by an antibody that is directed against an allergen that is made up of an IgE. That's the basis of the antibody, and it binds to cells, including mast cells and other cells, that will immediately degranulate upon exposure to the IgE bound to the allergen. And typically we see symptoms within 1 hour, and that can progress to anaphylaxis. So it's an immediate type of allergic reaction, and it tends to resolve quicker than other allergic reactions, but it's very dangerous during the window in which it's active. So let's give some historical background about alpha-gal and how this syndrome initially came into our consciousness. So it really wasn't that long ago, well within the lifetimes, I would say, of everybody here, that alpha-gal was first described. So alpha-gal was first described in 2008 in this paper in the New England Journal of Medicine. Essentially, they noticed that a lot of patients were having anaphylactic reactions to cetuximab, which is a chimeric mouse-human IgG monoclonal antibody that they were starting to implement frequently against EGFR, oftentimes in conditions like nasopharyngeal carcinomas, etc., and that predominantly these reactions were happening to patients from the southern states, including Tennessee, North Carolina, and Arkansas. And so in this population of patients that was identified in this New England Journal of Medicine study in 2008, of the 76 patients who had developed anaphylaxis to cetuximab, they narrowed it down to an IgE antibody in 25 of those patients, and really they essentially figured out that this was an IgE against that alpha-gal carbohydrate in those 25 of the 76 patients who had anaphylaxis to cetuximab. So that's based on a lot of biochemical data that I'm not going to get into. There were methods by which they identified that it was actually a carbohydrate that was the target of IgE in these patients. That's really groundbreaking in our field of allergy and immunology because, like I said, before this, all of the IgE that had been described was targeted against protein allergens. And the following year, in 2009, after the description of several patients who were having delayed reactions to red meat, a lot of these, now that we had the knowledge that patients could have IgE against alpha-gal and that alpha-gal is a carbohydrate that is bound to mammalian proteins, a few other researchers from the University of North Carolina and the University of Virginia got together and they pooled their patients who had delayed onset red meat allergies, and they thought, okay, maybe it's an alpha-gal IgE that is causing these delayed onset red meat allergies also. And in fact, that's what they published in the literature in 2009, that of these 24 patients with red meat allergy, they all had alpha-gal IgE as the cause of their symptoms. And over 80% of those patients reported a prior tick bite. And just to describe what you're seeing in that image on the right side, so this is an intradermal allergy test. So it's an allergy test for a delayed allergy. So most allergy skin tests that we do are the skin prick test, where we scratch the skin, see what the patient is allergic to. This is what we call an ID test. It's an intradermal test where we inject a little bit of that product that we're trying to test for under the skin and watch for what happens. You can observe at 15 minutes, you can observe again hours later. And what they found is that these patients had reactions when these tests were placed intradermally that tended to persist for not only during the immediate read, but several hours afterwards. So that's what alpha-gal syndrome is. And essentially, we know that the majority of patients who have alpha-gal are going to present in a certain fashion, like I had discussed previously, where they have delayed symptoms, and it frequently occurs with red meat ingestion, and they have an anaphylaxis type of picture. That's the classical alpha-gal patient. However, not every alpha-gal patient presents the same way. There are some alpha-gal patients that present with gastrointestinal distress as their predominant symptom, whereby, yeah, they have the food ingestion, yes, they have this delayed presentation, but they don't have cutaneous symptoms. They really predominantly just come in because they have upset stomach, either angioedema or of some visceral organ, or just they don't tolerate the digestive process because of their alpha-gal syndrome. That's a certain group of patients. And then there's another group of patients who will come in with purely cutaneous symptoms from alpha-gal, and they present as what we call chronic urticaria. Chronic idiopathic urticaria is, of course, a condition where a patient has hives that occur sporadically. They can occur at any time of the day, and they occur most days for a period of more than 6 weeks. Now, we distinguish chronic urticaria from food-induced urticaria typically because chronic urticaria, like I said, can happen sporadically any time of the day, whereas if a patient has a food allergy, we usually think, okay, it is going to present immediately after they eat the food that they're allergic to. Well, if the patient is not developing symptoms of reaction for 3 to 6 hours afterwards, that can really look a lot like chronic urticaria, and it can be really difficult to trace it back to what they're eating during the day. So, at least in the Southeast, what's often done now is patients with chronic urticaria are screened for having alpha-gal as part of their workup for chronic urticaria. And I have one such patient. I'm going to put in a plug for this article that I submitted to the New York Times Magazine, got published there. This is a patient of mine with chronic urticaria who was found to have alpha-gal, really just raising awareness of alpha-gal as a cause of chronic hives. So the image you can see on the left side really describes the symptom spectrum of patients with alpha-gal. You can see that in extreme situations on the far right side, patients with alpha-gal are going to come in with anaphylaxis. On the farther left side, they're going to come in with isolated gastrointestinal symptoms only, and then everything in between can be the presenting finding of a patient with an alpha-gal reaction. And I want to draw attention also to what we see on the right side. As with any other allergic reaction or anaphylactic reaction, there are certain factors that can lower the threshold for having a severe reaction, and there are certain specific findings that might make one patient more likely to have a severe reaction than other patients. Obviously, if a patient has a higher IgE level, they're much more likely to have a severe allergic reaction than if their level is relatively lower. So the alpha-gal lab will report up to 100, but I've seen patients with levels of above 100, so off the charts when we get the lab drawn. And those patients are much more likely to have a severe reaction than an alpha-gal patient with a level of 10, for instance, which is also something that you'll commonly see in these patients. There are also cofactors and exposures that can enhance the likelihood of having a serious allergic reaction. File that away because we're going to talk about that briefly, of course, as it relates to the intraoperative setting. But those cofactors can include things like alcohol, exercise, or anything that increases the temperature of the body, and NSAIDs. Here's where we're likely to find alpha-gal syndrome currently based on its distribution in the US. So between 2010 and 2022, so around the time alpha-gal came into consciousness and over the next 12 years or so, there were over 110,000 cases reported in the US. Really astonishing considering that it was a case series of 25 patients in 2008 and then a case series of 24 patients in 2009. And really over that time, since we became aware of it, we've picked up more than 100,000 cases of alpha-gal syndrome, and almost all of them are identified in this area where the Lone Star tick is currently likely to be present. But there are other cases reported in other countries, for instance, in Japan and in parts of Europe, and we think that that's not the Lone Star tick in those cases, but there are other ticks that can sensitize individuals to alpha-gal. I will say that if you go on Google and you search alpha-gal and you look up what people are writing on alpha-gal forums, there's a lot of misinformation there, just like there is with relation to any number of other medical conditions, right? I think we've all interacted with this at this point. And you'll see some websites that say that, if you have alpha-gal, it's not just dairy, it's any mammalian product, it's anything that contains, it's not just red meat, and it's not just certain medications, it's anything that is derived from mammalian products. It's dairy, gelatin, carrageenan, and then they'll get into really exotic ingredients, things like stearic acid. The true relevance of the really rare exotic ingredients is yet to be established, I'll put it that way. But we do know that around 10% of patients only are going to react to dairy products. Things like gelatin and glycerin reactions, much less common in patients with alpha-gal. So for the vast majority of alpha-gal patients, they can be counseled that, yes, they need to avoid red meat, but they don't need to go so far as to avoid dairy and really just cut out anything that could be possibly derived from mammalian meat, because that's a bit of an extreme reaction. So here is how I typically counsel my patients with alpha-gal syndrome on how they're going to proceed and how they're going to live their lives living with this condition. It can be a little bit limiting, but for the most part, these patients can live pretty much normal lives. They just can't eat red meat, as many people around the globe do not eat red meat. So, as sad as it can be to avoid red meat for a patient who really enjoys eating red meat and has that as part of their diet, it's not incredibly burdensome. I do recommend that they use caution with high-fat dairy products like ice cream, but for the vast majority, I don't tell them that they have to strictly avoid dairy unless they've specifically had a reaction to certain dairy products. And then they should modify their medications if they have any animal-derived medications. So for instance, patients who are on with chronic pancreatitis who are on animal-derived pancreatic enzymes, we typically recommend that they switch over to more non-animal derived. There are vegetable-based pancreatic enzymes now that are not quite as effective, but nonetheless are not going to cause an alpha-gal syndrome reaction. These patients do, of course, need to carry an epinephrine injector with them at all times, as all food allergy patients do, to just in case there is an accidental ingestion of the food that they're allergic to, or they're exposed in some other way to alpha-gal. In terms of what we do with these patients over the long run, these are all patients that need to establish with an allergist and immunologist, and we typically have a long-term relationship with them. When I see them back for their annual visit, I always ask if they've had any further tick bites, if they are somebody who spends a lot of time out in the woods, if they're a hunter or a hiker, if they're still taking the precautions to prevent further tick bites, which can exacerbate their degree of sensitization. We also recheck their alpha-gal specific IgE level annually. So it's interesting because in most adults with food allergies, by the time you're an adult, you're probably not going to outgrow the food allergy that you have. Alpha-gal is different because it's an acquired food allergy in adulthood. A lot of times it does tend to go away over time also. So we recheck this level every year because it may start to trend in a direction where it's getting lower and lower and lower. And then finally, when it gets below 1, we typically deem that these patients are eligible for a food challenge where they can come in, eat a burger under our observation, and then we watch them for usually a 4 to 6 hour period afterwards. And if they don't react, then that's an indication that they have outgrown this alpha-gal allergy. So there is hope for a lot of these patients to overcome it. In those that are going to overcome it, the median time to resolution is 7 years, but of course, not everybody does. Some people are stuck with this condition for life. So within the intraoperative setting, I know my colleagues are going to cover this here shortly, so I don't want to get into too much, but I will say that there is a risk of severe allergic reaction in patients with alpha-gal. That risk comes from, of course, unintended exposure to mammal-derived products because these patients are going to be receiving medications and other products that they may have never gotten before, and they may not know that they're mammalian-derived, and it's on us, therefore, as healthcare providers to counsel them and to make sure that what we're giving them is not likely to provoke a severe allergic reaction in these patients. Plus, if they're going under the knife and going to the OR, they're going to be unconscious and therefore unable to verbalize that they are allergic or that they have this particular allergy. I mentioned earlier that there are cofactors for anaphylaxis, and those are things like body heat, NSAIDs, etc., alcohol. Physiologic stress, so the stress of undergoing a surgical procedure or any procedure, and the medications that can be given that can raise the patient's body temperature, and especially if they have other reasons to, or if they have other cofactors for anaphylaxis that have been present over that time period, that's going to increase the likelihood that the patient has a severe allergic reaction. So something to be mindful of and monitor for. And then if you are given the patient something parenterally, so through an IV, that shortens the time to the onset of a reaction. So I want to go back to the initial study that I talked about where the patients were getting cetuximab. Those patients were actually not experiencing delayed allergic reactions to alpha-gal. They were having shorter onset IgE-mediated reactions to cetuximab. The reason for that is because this is not a protein, this is a carbohydrate. When it is given through the IV, the IgE, the preformed IgE antibodies, can interact with it relatively quickly, and so the symptoms can occur within an hour. Whereas if it is being consumed, like in a hamburger or in a piece of steak, that carbohydrate has to undergo digestion, and then it'll enter the bloodstream. So that's why the exposure doesn't happen for several hours, and the reaction doesn't take place for several hours when alpha-gal is ingested in red meat. But if it's in a medical situation where you're giving the patient a product that is that contains the alpha-gal carbohydrate through the IV, you're going to shorten the length of time to onset of symptoms. So from an allergist immunologist standpoint, this is what I would recommend as a pre-op approach to alpha-gal syndrome. If I had one of these patients in my office and I was counseling them on their alpha-gal and counseling them on their upcoming procedure, and I had time before their procedure, these are the things that I would do before the patient went off and had their surgery. First, I would confirm that the patient has true alpha-gal, that their history is consistent with alpha-gal allergy, because obviously, just like with everything else, they can be false positive. This might be somebody who is eating burgers, eating cheeseburgers, and they're totally fine, and maybe they had a low-grade positive alpha-gal IgE level, but they don't actually have the allergy. Next, I would want to assess the clinical severity of the allergy. Is this one of these patients that has only GI distress or only hives, or is this somebody that has ever had a severe allergic reaction? I'm then going to look up what their most recent alpha-gal IgE level was. Was it, if it's not available, of course, or if it was more than a year ago that it was last checked, then I'm going to recheck that level, see what it is before they head off to surgery, if, of course, that I have enough time to do so. Then I'll ask whether they've been exposed to things like anticoagulation in the past. And I know my colleagues are going to talk about why anticoagulation in particular is relevant to patients with alpha-gal. So ask, have you been exposed before? How did you tolerate it? Did you have alpha-gal at the time? Or did you have known alpha-gal at the time that you were exposed? And did you do okay with it? Or is this something where you were concerned, or your doctors were concerned about a reaction then? And then the anticoagulation can be selected based on the patient's profile and based on all of that available data. Here are my references for the presentation. That concludes my introduction to alpha-gal, and I'll be happy to take questions at the end of the session.
Thank you very much, Dr. Kahwash. This presentation sort of set the platform for the next two presentations. So next would be Dr. Nourian. Dr. Nourian is an adult cardiothoracic anesthesiologist who is currently an assistant professor at UCLA in Los Angeles. He initially became involved with alpha-gal work after treating several patients with alpha-gal syndrome as a resident at Vanderbilt University Medical Center. So subsequently, he has compiled some perioperative recommendations for patients with alpha-gal undergoing surgery. He's the lead author of our review article that is available in PubMed. It is PubMed Central, available to everybody who wants to download it. It has been published in JCA in 2023. Dr. Nourian's other research interests include capacity building and resource-poor settings with an emphasis on education and improved access to capnography for safer anesthesia. But now he will talk to us about alpha-gal. My patient has alpha-gal. What do I do now?
Alrighty, Dr. Riess, thank you so much for the introduction, and Dr. Kahwash, thank you for the introduction into alpha-gal syndrome, the pathophysiology, and how these patients present. And so today I'd like to change the gear a little bit to kind of talk about, well, how does this apply to the anesthesiologist? How does this apply into the operating room? So if your patient does have alpha-gal, what do I do next? Just to disclose, I have no financial relationships or any disclosures to present. The objective of this purpose is just to identify, are there any safe substitutes for a patient with alpha-gal syndrome in the operating room, and how to approach the whole perioperative experience for this patient. The management of alpha-gal syndrome in the perioperative setting begins at the preoperative visit and continues until discharge. Patients with alpha-gal syndrome can present with delayed onset reactions, as Dr. Kahwash went over, to mammalian-derived products with symptoms as mild as itching and all the way up to as anaphylaxis, as we learned in the previous presentation. It is important during the perioperative period to not expose patients to possible triggers of the alpha-gal syndrome. In the next couple slides, I will discuss common mammalian meat products as they are found in the operating room, and including products that may be found post-operatively. Also, we would discuss different ways of how we can treat alpha-gal syndrome patients and serve as leaders in the coordination of care for alpha-gal patients. Mammalian meat products can be found in a variety of products in all stages of the perioperative setting. Common perioperative mammalian products include possibly gelatin, antibodies that we use in the operating room, such as, rejection and medications, surgical glues, such as like Surgicel or other products like, gel foams, heart valves that have been derived from, bovine heart valves, albumin that we use in fluid resuscitation, and potential enzyme therapies. There's also a hypothetical risk of certain products containing alpha-gal due to being derived from mammalian sources. As again, Dr. Kahwash went over this, these are all theoretical. However, it is still our impetus to make sure that we are not exposing patients to potential risk. These products include potentially glycerin, magnesium stearate. Again, however, these reactions to these ingredients have not clearly been demonstrated. And then assays to prove alpha-gal content of these have not fully yet been performed. However, this is the next step of future research, specifically of looking at alpha-gal syndrome in the operating room setting. In this table, we'll describe some common medications that you may encounter in the perioperative setting, which may have either active or inactive ingredients that contain mammalian meat proteins, which can trigger an alpha-gal patient. In this table, we've also broken this down by either drug or device class. As you can see, mammalian meat products can be found in either the inactive or inactive components of this. And note, one of the things is that certain tablets or capsules, such as acetaminophen or oxycodone, may contain mammalian meat products, and these can vary by manufacturer to manufacturer. In the next slide, I'll describe how you can determine if any of these inactive ingredients are in these. But before we move on to that, I want to point attention to certain medications that we use potentially in the operating room. And these include induction agents, of no volatile agents, have no potential to contain alpha-gal. And then various anticoagulation medications, which Dr. Siegrist will go over. And then finally, different devices that we potentially could use in the operating room for surgical purposes. In this slide, in order to reduce the risk of exposure to mammalian meat products, active and inactive ingredients can be looked up on the Daily Med database. This is an NIH-sponsored database in which each medication by each manufacturer, as looked up by an MPI code, can be elucidated. This one in this, for example, is a particular midazolam, and by this particular manufacturer, and you can look to see if there's any sort of inactive ingredients. Practitioners can figure out if any of these contain potential mammalian meat products prior to going back into the operating room. So as the anesthesia provider, you should be leading and coordinating a multidisciplinary team for better patient care outcomes. This includes consultation with an allergist, such as Dr. Kahwash, prior to the surgery, coordination with the surgery team, including the surgeons, nurses, and pharmacists, and lastly, to come up with a clear plan for medications prior to the operation for intraoperative and postoperative care, with clear protocols for handoffs of care. What that can mean is that creating, like, let's just say, an alpha-gal safe bag, and anything that has any medications that you think they would use, to pre-select these prior to going back to the operating room, and then screening with the pharmacist any medications this patient could receive postoperatively on the floor that potentially are free of any sort of potential mammalian meat products. In this slide, I have listed potential alpha-gal triggers and their alternatives in the perioperative setting. Again, to note that these are theoretical. However, we want to do anything we can do to reduce the risk of a potential anaphylaxis reaction. As you can see, these are broken down by different categories. Induction agents, different things. So, for example, propofol, if there was a theoretical risk, you could use etomidate or ketamine for induction. Alternatively, you could use all vegan propofol, which is soy based. Surgifoam using different techniques to reduce the risk of bleeding in the case, using transexamic acid or other surgical techniques that may be present. In lieu of bovine pericardium that you may see in cardiac surgeries, Gore-Tex might be something that could be potentially used. And again, all of these would be decided upon ahead of time with the surgeon and the perioperative team. And then I will put one plug in. There are different groups right now who are moving towards using all vegan medications and products in the perioperative setting for different purposes, but also serve the purposes of alpha-gal patients. Lastly, it's worth noting that all anesthesia providers need to be ready to handle any anaphylaxis that could occur with alpha-gal patients. Similar how you would approach any patient with an intraoperative anaphylaxis. And then the last thing I'll say before handing off to Dr. Siegrist is, in any sort of transition of care, it is imperative that you hand off any sort of case. So if you go off for a break or you're handing off to a different anesthesia provider, being able to communicate the importance of this allergy, just so that way medication errors don't occur. Thank you so much.
Very good. Thank you so much, Dr. Nourian. Before we come to our last presentation, I have pre-screened some of the questions, and there were 2 or 3 comments that obviously the screen share did not work, and I would ask the IRS staff to please check if that was the case or was not the case. We continue. Good. So last but not least, Dr. Kara Siegrist is an associate professor of anesthesiology at Vanderbilt University Medical Center. She did complete her residency and her cardiothoracic fellowship here at Vanderbilt. She is now the director of Vanderbilt's liver transplant anesthesia program and the combined heart and liver transplant program as well. She's also the anesthesia director for the cardiac catheterization and electrophysiology labs. Her research interests around high-risk anesthesia cases, both in the cardiac and liver transplant rooms, and some other complex cases, for example, nephrectomies with IVC thrombectomy, and so forth. Her topic today regarding alpha-gal is implications of alpha-gal syndrome during cardiovascular surgery. Dr. Siegrist.
There we go. You can hear me now. Thank you, everybody, for joining in and hanging in there with me till the end. So the tail end of this talk, hard to follow these other 2 acts, but my part is really going to hinge around the practical applications of our experience here in the South, treating patients who have alpha-gal syndrome, who are presenting for some type of cardiac or vascular procedure, or really anything that involves receiving anticoagulation in the operating room, most typically in the form of heparin. This is also one of my favorite stories to tell. When I first started giving talks on alpha-gal a couple of years ago, I told my husband, who is not medical at all in his defense, that I was talking about alpha-gal, and he thought that it was like some form of like a dominant female slang, and he was like very confused for a while as to how this was a grand rounds talk. But anyways, here is my disclosure slide. I am an Octapharma advisory board member, but I will not be discussing anything that is pertinent to that conflict today, nor will I be discussing any off-label or investigational use of products. So a couple of years ago, I was staffing in our electrophysiology lab, and I had a patient who came in pretty unexpectedly carrying this diagnosis of alpha-gal syndrome. So I went to my EP colleague and said, gosh, this patient has alpha-gal, and I'm kind of worried about proceeding. And his response was, what's alpha-gal? And so that is when I knew that we needed to come up with a better sort of solution to this problem. So I got together with a couple of our wonderful allergists, and we put together this algorithm with which to follow, and then published our implementation of our safety protocol for patients who present with alpha-gal and require a surgical procedure that is going to involve some type of parenteral anticoagulation, most commonly heparin. So this includes, cardiac surgery, vascular surgery, some neurosurgical endovascular procedures, electrophysiology procedures like ablations, cardiac cath lab procedures like structural heart operations and cardiac catheterizations, hepatobiliary procedures that may require heparin for vascular clamping. I mean, the list really goes on and on. So this is our algorithm. I know this is a very intense flowchart, so I'm going to break this down sort of section by section to review our guidelines. At the top of the flowchart algorithm really just states that there's a patient that's presenting for a procedure that it requires IV heparin administration. And the first branch point is whether or not there are recent alpha-gal IgE levels available. And the first one that we'll undertake here is the segment that we'll look a bit closer at when there are no alpha-gal IgE levels available. So we break this down further into elective cases versus urgent or emergent cases. The easiest is if this is elective, we recommended postponing the case for an alpha-gal panel to be sent out and an allergist to consult, and with which the allergist can kind of take it from there and sort of guide with recommendations in the perioperative period. And their alpha-gal IgE levels will sort of allow you to be able to risk stratify their likelihood to react to some of the perioperative substances. For urgent or emergent cases with which you don't have the luxury of waiting for that alpha-gal panel to come back as typically a send-out lab, we're really left with our clinical judgment to help guide us. So history is really key here. So taking a good intake from the patient about their alpha-gal severity, the timing, the reactions is really critical. For low clinical suspicion patients, we do recommend pre-medication, and then we undertake a loading dose heparin challenge. And after their surgery is complete, then continuing to send off that alpha-gal panel and consulting the allergist to help guide their future therapies and risk for future reactions. For those with a high clinical suspicion of alpha-gal and a true emergency, we recommended going straight to an alternative anticoagulant, which most commonly in the operating room would be bivalirudin for emergent cases. If the case is kind of somewhere between it's urgent but not emergent, the allergist can come and do an intake and possibly do like an immediate desensitization prior to surgery. Or for places who do not have easy and open access to allergists, like a large academic medical center has the luxury of, desensitization protocols can still be completed, but this most commonly happens in the ICU settings. So the pre-medication regimen that we adhered to is listed here, and this is what we use for our protocol for tracking our safety outcomes in our study. And it, really essentially it consists of all the usual suspects, including steroids, either PO or IV, and some form of histamine blockade. So the heparin loading dose challenge is kind of like a protamine test dose, if you will. So since IV administration bypasses the sort of usual mechanisms that delay the reaction in alpha-gal patients, reactions typically occur very quickly after the administration of the offending agent. So we protocolized our heparin challenge to include a 10 unit per kilo heparin IV bolus, and then carefully observing them for 15 minutes, and then proceeding either based on their reaction. If it was negative, you could proceed with the full heparin loading dose for the duration of the surgery. If it was positive, obviously treat the reaction and then switch to an alternative anticoagulant. If you're going to have an allergic reaction, the operating room is one of the safest places to do that. And so that's why we undertake this in the operating room after general anesthesia has been induced. The other half of the chart is where an alpha-gal IgE panel is available, and this value really allows us to further risk stratify based upon their IgE levels. So the lowest risk patient we defined as having an alpha-gal IgE level of less than 8. And so for these patients, we did still recommend pre-treating the patient with the pre-medication regimen we previously discussed, and then undertaking the heparin loading dose challenge. Again, if positive, switch to an alternative anticoagulant. However, if negative, you're, kind of free and clear to proceed with the full loading dose of heparin. The intermediate risk patients we defined as having an alpha-gal IgE from 8 to 50. So for elective cases, allergy really should be consulted for these patients preoperatively. And these patients can undergo heparin skin testing and possible, temporary desensitization prior to surgery. There is some controversy with the heparin skin testing, given that there is a fair amount of variability in alpha-gal concentration from one heparin lot to the next. Some suggest that using the same heparin lot for bypass or in the operating room is safer if that skin testing is negative. It just isn't always wildly feasible. For urgent or emergent cases, we did still recommend pre-medicating the patient and proceeding with the heparin loading dose challenge, and then kind of forking based upon their reaction to the loading dose. And for the highest risk patients, we define those as having an alpha-gal IgE level of over 50. For elective cases, they should be admitted for heparin desensitization preoperatively. And for urgent or emergent cases, an alternative anticoagulant should just be used, like bivalirudin or argatroban. You may be thinking this sounds like a lot of work just to use heparin. Why not just give them one of these alternatives? The basic premise is that there is not a great alternative. As a cardiac anesthesiologist, I will do almost everything in my power to not have to do a case with bivalirudin or argatroban. These direct thrombin inhibitors are very good at anticoagulation, but then, as anesthesiologists, we're sort of left to deal with the aftermath of them, which includes the inability to reverse them quickly and a variable half-life that just sort of leaves us to mop up the bleeding in the operating room. However, should you need to end up in a situation where you do need to use a direct thrombin inhibitor, the dosing protocol we used is referenced in the paper at the beginning of the slide. Most institutions have a dosing protocol for these agents already. And I have included here an example of bivalirudin dosing that was published a couple years ago that is very comprehensive and it's great and is very similar to the protocols that we use as well. The topic of which type of valve, mechanical versus bioprosthetic, to replace in patients with alpha-gal syndrome remains pretty controversial without, really strong evidence one way or the other. There are some reports of early bioprosthetic valve breakdown in patients who have alpha-gal syndrome. Bioprosthetic valves should be decellularized, though some may still have some reactive antigenicity and have the potential to react still. There are some case reports of patients with very high alpha-gal IgE levels that had acute allergic reactions after implantation of bioprosthetic valves, but most of the evidence out there is really in the form of case reports. That's why strong data and recommendations really are lacking. So what's next? The FDA has approved an intentional genetic alteration line of pigs, that also known as alpha-gal knockout pigs, also known as gal-safe pigs, that are genetically modified with the intent of having their mammalian products be safe for patients with alpha-gal syndrome due to their lack of alpha-gal carbohydrate on the pig cells. So more to come, hopefully, on this in the future, and maybe even the expansion to other mammalian lines, such as cows as well. So these are my references. So this concludes my portion. So I will turn this back over to Dr. Riess to kind of moderate us through the Q&A session.
Very good. Thank you so much, Dr. Siegrist. This ends our presentation section. We have about 10, 11 minutes for question and answers. Again, this is a live session, so please feel free to submit them for the Q&A portion, which we all have access to. But let me start with a question that was sent to me by email before the webinar, and that was by a colleague of ours, a provider in Florida, who himself is alpha-gal positive, and is wondering, other than avoiding meat, what precautions he has to take when dealing with medication that could potentially trigger this in patients. Again, he's a provider.
Yeah, thank you for the question. Well, I obviously can't give medical advice without examining the patient, but I would recommend that this colleague establish with an allergist and immunologist and seek their input. Having said that, I think the likelihood of an allergic reaction as a practitioner is very, very low. Ingestion of some form has to take place, or entry into the bloodstream of an alpha-gal carbohydrate has to take place in order for the person to develop symptoms of reaction. Simply being in the same room as alpha-gal containing products is very unlikely to cause an allergic reaction. And for the most part, food allergies, the food allergen does not get aerosolized. There are a couple of examples of food allergies being aerosolized, causing a problem just by going into a room where a food allergy is being cooked and developing symptoms from that standpoint. But red meat is not one of those allergens. Shellfish is the main one that we think about. For instance, lobster boils and things like that. People with lobster allergies can have anaphylactic reactions just by being present when the cooking is happening without ingestion. Outside of that, though, I really don't think that an occupational exposure or a food environmental exposure is likely to provoke an alpha-gal reaction.
All right, very good. Thank you so much. I'm going to go by the order they were put into the Q&A section of the Zoom meeting. So the very first question was, in patients with identified gelatin allergy, how often will this be part of an alpha-gal syndrome versus just an isolated gelatin allergy?
Thanks. Yeah, I'll get through these quickly because I want my colleagues to have time to respond to their questions as well. But I would say that anybody with a gelatin allergic reaction should be also tested for alpha-gal. I would imagine that a lot of these patients are going to, I don't know what the exact percentage is, I don't think anybody knows, but I would imagine that a lot of these patients who are allergic to gelatin-containing products really have alpha-gal allergies. So, obviously, theoretically, it's possible for them to have a gelatin allergy and not have an alpha-gal allergy. But if a patient has a gelatin allergy, there's no reason not to also test them for alpha-gal.
All right, very good. The next question is, how does the Lone Star tick cause the alpha-gal versus are there other ticks that can cause this as well in the United States?
Yeah, so I think I addressed this possibly after the question was posed, but there are other ticks that can cause alpha-gal sensitization. I don't think that there's anything specifically unique to the Lone Star tick and its ability to cause alpha-gal allergy. It just happens to be the one that we have in the U.S. that's likely to do so. I don't know if that has to do with the biology of the tick or just the density of that tick within that particular geographic area, and the fact that there also happen to be a lot of wildlife, deer, etc., that are abundant within that part of the country as well. So I think that's more of a biology question. So I'm not sure what it is about the tick in particular, but that's not the only tick bite that can sensitize a patient to an alpha-gal.
All right, very good. I'm going to skip over the next one that was actually explained by you. How does tick bite trigger the syndrome? And the next question is more towards Dr. Nourian. I would think if you could comment on the website Vegan Med, formerly website Vegan Med, that is now called pillclarity.org.
Yeah, and thank you for the question. I actually am not familiar with pillclarity.org. I was looking it up currently, but I think any of these resources are helpful for identifying potential products that are fully vegan. And I think that would be the safest way to approach any patient with alpha-gal syndrome. I know that there are some companies based out of India that manufacture fully vegan medications specifically for the operating room. I will kind of jump ahead towards another question that I saw on the list if there's any comprehensive list of anesthesia medications that have alpha-gal reactions. And I would say that there is not. And I think that this is something that's kind of institution to institution. As Dr. Kahwash mentioned, there's a lot of online forums per se. One of them is alphagal.org that kind of starts with the list. However, these aren't fully validated in a lab setting to say that this potentially inactive ingredient had this sort of immune response. So I would say the best answer for this is to work through each individual medication with your pharmacist to kind of create something specifically to your institution and what are the manufacturers of the medications at your institution.
Right, very good. Does the IgE titer correlate with the severity of the symptoms?
I will say yes, it does. It's not a linear correlation that anybody has very neatly mapped out and said that if it's this level, the patient's going to have GI symptoms. If it's this level, the patient's going to have urticaria. If it's this level, angioedema. If it's this level, anaphylaxis. But broadly speaking, yes, if somebody has a very, very high IgE level to alpha-gal, that correlates with their likelihood of having a more severe allergic reaction to alpha-gal. And yeah, that's there is correlation there, but it's not perfectly understood.
Okay, and then let's jump again forward a little bit along the same level of topic. How long does it take to get an IgE level? When you work in the pre-op clinic, you identify somebody and you want an answer about the IgE level.
Yeah, it takes about a week. Typically, it's a send-out lab. Not every lab in the country is running it. Vericor is the lab that we were using. AREP also runs it. But yes, it takes about a week from sending the sample to having the results. So for that reason, and that's a really good point, for that reason, if a patient is being brought in emergently for potential intervention where they require heparin or some sort of other mammalian product, we can't just get an alpha-gal level right there at the point of care and have that change our clinical decision making. We have to go by what their most recent alpha-gal level was, if there even was one. And sometimes we don't have an alpha-gal level to guide us, as Dr. Siegrist pointed out in her algorithm.
All right. There is one for Dr. Siegrist here. What about blood product administration during surgery? Any special precautions there?
Yeah, interestingly, the B blood group antigen, the RBC antigen, is very structurally similar to the alpha-gal carbohydrate. And so patients with A or O blood types that have anti-B antibodies may potentially be more likely to cross-react with alpha-gal. This is, potentially not causal and maybe just correlative, but just being aware of that reaction, and trying to avoid giving patients B type blood, which if they're A or O, you probably wouldn't be doing anyway.
All right. Are there any vaccines that contain products that cross-react with alpha-gal?
Not to my knowledge. Not to my knowledge, yeah. And there are some vaccines that contain gelatin. MMR is one of them. And so, yeah, actually, now that I'm thinking about this, but again, gelatin, the majority of patients with alpha-gal are not going to react to gelatin. But there are, I can't think of all of the vaccines that contain gelatin right now, but yes, those are the ones that would be more likely to cause an alpha-gal reaction in those patients.
All right. There's a question, how do you navigate products with ambiguous ingredients that could either be plant or animal derived, such as glycerin and magnesium stearate? What protocols are in place? And again, I might want to add my own experience. I've recently had a patient with about 200 medications on an allergy list who was alpha-gal positive. Again, Tylenol, not the acetaminophen, but the ingredients of that tablet could make this an alpha-gal trigger or could not make it. It depends on the manufacturer. So how do you go about these ambiguous medications?
I mean, I think sometimes in the operating room, you have to work with the data that's available to you and the information that you have. Pre-medicating a patient is, potentially a helpful move that you can make to help reduce the risk of having a reaction. And then like Dr. Nourian talked about, trying to cross-check the inactive ingredients. Those are usually going to be what is the inciting offending agent for these patients.
Is there any value to tryptase levels?
Certainly, yes. I think that the value of the tryptase would be if you are concerned about a potential alpha-gal reaction intraoperatively. I know you all will send a tryptase sometimes if there's concern for possible anaphylaxis, where, for instance, if there's unexplained drop in blood pressure in the OR. I'm not going to get a screening tryptase on all of my patients with alpha-gal syndrome, but if there is elevated tryptase, that raises the likelihood. That's another factor that I didn't mention that raises the likelihood of a patient having a severe allergic reaction. So in an outpatient setting, I may get a tryptase on an alpha-gal patient if they've had multiple severe allergic reactions.
Right, so we have two more questions, and then I guess we will have to finish today's session. One says, I currently work in an ASC we do not have a pharmacist, and often the brand of the anesthetic medications changed, and all depends on the costs. We don't allow any alpha-gal patients due to this practice. Do you feel that is appropriate?
I think that's appropriate. I think that if there was a anaphylaxis reaction, it'd be best dealt within a hospital setting, looking at the aftermath of things. And one last thing I'd like to add for different medication lists is I always ask the patient what they've tolerated in the past. If they tolerate this brand of Tylenol in the outpatient setting, then they should probably tolerate this in the postoperative setting.
All right. And is there any way to tell if a de novo reaction during heparin administration is alpha-gal or if it's a heparin reaction?
Gosh, in the heat of the moment, I think that would be pretty hard to, parse out in the operating room. I think, obviously the important part is just to treat the reaction, stabilize the blood pressure, and decide, what the next step is, if you need to abort the case, if you're at the point in the procedure where that's even an acceptable option, or if you need to switch to an alternative anticoagulant at that point.
All right, very good. Thank you to the panelists for an excellent afternoon. We have exceeded our 1 hour allowance. To the audience, thank you so much for chiming in. Please feel free to submit your remaining questions or those that we have not answered to the IRS website, to the doc matter, and we will try to answer them this way. And then hopefully we'll see all of you in Montreal next year. Thank you so much.